Good afternoon, class. And today we will be continuing with benign breast diseases. I mean, breast disease proper. And initially, I'll be talking about investigations, followed by um, benign breast diseases, and the next class will be malignancy. I will probably require about a class and a half for malignancy, so I will not be starting today. And at the behest, let me wish you all a happy Dashera. Uh, Today's class will be rather short, like last time, maybe 30 minutes, 35 minutes. Then we'll be starting with CA breast. Whenever a patient comes to you with any breast disease, the first and the foremost important thing is the patient history. History should be carefully taken, and history most of the times will take you where exactly you're dealing with. So history of a breast disease is as important as anything else, uh, as then examination. So first patient history, followed by physical examination, followed by investigations like ultrasound, biopsies, FNAC, then core cut biopsy, true cut biopsy, and probably MRI. These are the things that we will be dealing in CA breast. And I already told you about Bernard scoring, did I not? Yes, I already did. Now, whenever a patient comes with a breast disease, the first and the foremost thing is that you will be checking for patient's history. And in the history, the most important thing is patient's age, okay, patient's reproductive history. That should include age of attaining menarche and age at which, if the lady is a menopausal lady, age at which menopause. This age of menarche to age of menopause is important to us because this is the interval in which the lady had a full exposure to the estrogen that was being produced by her in the body. And you all know estrogen is one of the risk factors for development of CA breast. Then including at the age of menarche, at menopause, and history of pregnancies, that should include full-term pregnancy, which is the first one. A previous history of breast biopsies also needs to be obtained. Okay, then in the history, what are the pathological findings? Okay, like any proliferative breast disease is there, if the patient has had a hysterectomy, again it is important to determine whether both the ovaries were in place or removed when the patient underwent hysterectomy. So simple hysterectomy or hysterectomy with bilateral oophorectomy. This is what you should know. In a premenopausal woman, a recent history of pregnancy and lactation should be noted. The history should also include if the patient was on hormone replacement therapy for regularization of cycles, that is combined pills. Okay, the family history should be taken in detail if there was any cancer in the family, okay, or the patient lady has used any contraception, any forms of pill contraception, not other forms of contraception, and menopausal status of any affected relatives of breast cancer. These are the histories that we have to be taking in order to understand exactly what we are dealing with. With respect to the specific breast complaint, the patient should be asked about history of a mass, okay, breast pain, nipple discharge, and any skin changes. If a mass is present, okay, if a mass is present, the patient should be asked how long it's been there, whether it is cyclical, that is whether it has got any role being played during the menstrual cycle. Okay, if a cancer diagnosis is suspected, inquiry with constitutional symptoms, all of them should be asked, like bone pain, weight loss, respiratory changes, and any similar clinical indications can direct investigation that could reveal whether we are dealing with a metastatic disease. So all of these things to be asked to the patient in the history of physical examination. And the next most important thing that we will be discussing about next most important thing that you are going to be seeing or doing in the case of breast lesion is physical examination. Physical examination is one of the most important things that we will be doing. The physical examination should begin with the patient in the upright and sitting position. It should always be in the sitting position. The breasts are carefully first inspected for any obvious masses, any asymmetry, and any skin changes. The nipples are inspected and compared to the presence of retraction, nipple inversion, or excoriation of the superficial epidermis, such as that of in Paget's disease. There is excoriation in Paget's disease. The use of indirect lighting can unmask subtle dimpling of the skin or nipple caused by carcinoma. Okay, what does it happen? When does it happen? Whenever the Cooper's ligament is under tension. Okay, so when you do an indirect lighting, you will be able to see the dimpling of the skin, of the breast skin. So simple maneuvers such as stretching of the arms high above the head, okay, and tensing the pectoralis major muscle may accentuate asymmetries and dimpling. If you carefully check in inspection or palpation, you will understand, okay, dimpling of the skin or nipple retraction is a sensitive and specific sign of underlying CA breast. Then, what are the other things that you should be looking in physical examination, general physical examination? Edema of the skin. Okay, what does edema of the skin produce? It produces something called as pudgy orange. And when does this happen? When the subcutaneous lymphatics are invaded by the cancer. Pudgy orange and tenderness, warmth, and the swelling of the breast, okay, are all the hallmarks of inflammatory carcinoma of the breast, are also known as mastitis carcinomatosa. The inflammatory changes in edema are caused by the obstruction of the dermal lymphatics, just under the skin lymphatic channels, by emboli of the cancer cells. Occasionally, a bulky tumor may produce obstruction of the lymph channels that results in overlying skin edema. This is not typically the case of inflammatory carcinoma, where there is usually no disease palpable mass, but diffuse changes throughout the breast parenchyma take place. So you should then decide if there is a mass or no. Okay, so basically what erythema, edema of the skin, okay, a palpable mass or a localized induration is only there. There may not be an obvious mass. Only about, if you check 100 patients, you will get about 38 to 40% of them suffering from a mass. Otherwise, it's only edema, skin changes, then localized temperature is there. Patient will not have fever. That is what should give you a suspicion. If the patient has fever, it indicates most likely you're dealing with breast abscess. Otherwise, you will most probably dealing with CA breast. Involvement of the nipple and areola can occur in carcinoma of the breast, okay, when the primary tumor is located just under the areola, that is subareolar position. Direct involvement may result in retraction of the nipple, flattening or inversion of the nipple, okay, and this all can be flattening and inversion can also be seen in duct ectasia. In these cases, the finding is frequently bilateral. It's usually bilateral duct ectasia. In these cases, the finding is frequently bilateral. Unilateral retraction or retraction that develops over months will have to make you suspect that the patient is suffering from CA breast. Centrally located tumors usually are very late to be diagnosed. Okay, but by the time you get centrally located tumors. Most of the times they are advanced, already infiltrated the skin in all probability. In all probability. Paget's disease. Okay. Peripheral tumors, what happens is there can be a distortion of the normal symmetry of the nipples by traction of the Cooper's ligament. Paget's disease is that condition of the nipple that is commonly associated with underlying breast cancer. Okay, underlying breast cancer. It was first described by Paget's in 1874. Yeah, 1874. That's the reason Paget's disease has got its name. There is often an underlying intraductal carcinoma whenever there is Paget's disease of the nipple. Paget's disease of the nipple. Clinically, dermatitis also can be same. Okay, that's the reason we have to be careful. Many benign conditions affecting the breast originate from the nipple, and then they will be secondarily involving the areola. Visual inspection should be followed by palpation always about the breast tissue proper as well as the regional lymph nodes. While the patient is in the sitting position, the examiner should support the patient and palpate each axilla to detect the presence of enlarged axillary lymph nodes. So what are the palpation lymph nodes that you palpate? They are already told you, the supraclavicular, the infraclavicular, similarly palpated for enlarged nodes. The patient lies and the breast is palpated. Palpation of the breast is always with the patient lying position, lying supine and on a solid examination surface. Whenever you locate a palpable mass, then you should be checking about the size, the shape, the symmetry, the size, shape, symmetry, and then consistency, then the location, whether it is fixed to the skin or the underlying muscle. And pectoralis major, even if the tumor is fixed to it, it does not indicate locally advanced disease. Please remember. Then you should know benign conditions such as fibroadenomas and cysts are usually firm in consistency, whereas carcinomas are less circumscribed and they are typically hard like a cork ball, hard masses. That's it. Then we will be moving about what are the other investigations that you will do for a not CA breast is a mass per breast mass. Okay, the first and the foremost investigations that you would like to do is an FNAC. It's called as fine needle aspiration biopsy. Historically, fine needle aspiration, okay, was a tool used to diagnose breast. So first, it was the breast disease that we first tried to identify with FNAC, and the needle size that you use is 22 gauge. Please remember, this is an entrance bit. 22 gauge needle is what you use for FNAC. An appropriately sized syringe is applied, and then on an alcohol pad the needle is repeatedly inserted into the mass and then removed, and then you will withdraw whatever is there and then put it on that buffered in a saline, and then you will fix it immediately with ethyl alcohol, and then you will do a FNAC, that is fine needle aspiration or fine needle aspiration biopsy. Then the slides are then given to or submitted to the cytologic evaluation of the aspirated material. The only problem is whenever FNAC, there is a limitation for it. What is the limitation? When you are evaluating solid masses in cytological evaluation, it does not differentiate between invasive cancer and non-invasive cancer. Why? Because you're not knowing about whether there is a breach in the basement membrane. You will never know. So that's the reason. But if FNAC, okay, if FNAC or FNAB demonstrate malignancy, you should always confirm it by going for a core needle biopsy. One clinical scenario in which FNAC or FNAB still has any utility is in the evaluation of a second suspicious lesion in the ipsilateral breast, which in a case of already known malignancy. Okay, already known malignancy. What is this information you can use? The information will aid you in determining the appropriate surgical plan. What exactly you're going to plan your surgery on this patient. Suspicious lymph nodes also can be evaluated by FNAC. Okay, and the specificity and sensitivity is about 90% and specificity is almost 100%. Okay, and this will help you determine whether that the tumor has spread to the axillary group of lymph nodes or no. Then you will be dealing with something called as core needle biopsy. Core needle biopsy is the method of choice, okay, to sample breast lesion. Core needle biopsy can be performed under mammographic technique, that is a stereotactic technique. It's called as ultrasound guided as well as MRI guided, magnetic resonance imaging guidance. Mass lesions that are visualized on ultrasonography can be sampled under ultrasound guidance, and then during stereotactic core needle biopsy, the breast is compressed and most with the patient lying prone position by the stereotactic technique. Okay, a robotic arm of the biopsy device are positioned by the computer analysis that can be seen in mammographic imaging. After local anesthetic is injected, the skin is a little incised and a core needle biopsy needle is inserted into the lesion to obtain the tissue with vacuum assistance. You have to use a vacuum assistance. These are the standards that are approximate number of core samples that to be obtained. A clip should be placed to the mark site of the incision so that you will include this incision in your future procedure for going for a modified radical mastectomy. Okay, and this is similarly how you use an ultrasound. You will even use a magnetic resonance imaging for the same. Okay, specimen radiography of excised cores is performed to confirm that the targeted lesions have been sampled and to do direct pathological assessment. Then there is something called as image guided localization with the I-125 rod. Radioactive seed and surgical excision can be required if the lesion cannot be adequately sampled through core needle biopsy. Then you have something called as incision biopsy. You will open, incise, and then take a incision biopsy from the lesion. But always remember that you clip it so that you can be using it upon this thing. And in core needle biopsy, depending on the size of the imaging abnormality, approximately 10 to 20% of the patients with diagnosis of DCIS on core needle biopsy are found to have invasive carcinoma